Good morning to lecturers and friends. We are from Group 3A and we're going to present a case on surgery and infectious disease.
In this video, we are going to talk about a case of a 40-year-old woman who came to the emergency department after a motor vehicle accident. She came in an unconscious and hypertensive state. After the arrival to the ED, she was then transferred to radiology to get a CT scan. CT scan then found out that she has peritoneal bleeding and left temporal lobe brain hematoma. She was then immediately taken for a surgery. 2 days after the surgery, it was found out that the patient was hemodynamically unstable and developed GTC seizure. Thus, IV phenytoin is given to the patient for the management of the seizure. In this case, patient is displaying the signs and symptoms of septic shock after surgery. Patient has a symptom of temperature of more than 38 degrees Celsius, heart rate of more than 90 beats per minute, WBC count of more than 12, systolic blood pressure less than 90 mm mercury, and serum creatinine of more than 2 mg per deciliter. So septic shock can be defined as persistent hypertension that requires vasopressin to maintain mean arterial pressure. Septic shock is also equivalent to severe sepsis plus hypoperfusion despite adequate fluid resuscitation. So the patient received 3 liters of ringer's lactate during the surgery. However, patient is still in hypertensive state during that surgery.
So next, we move on to drug-related problem of pharmaceutical care issue section. So we have identified 5 DRPs and also 3 PCIs. The first DRP is patient does not receive any antibiotics as surgical prophylaxis. Supposedly, patient should receive IV cefuroxime 1.5 gram given as a single dose at induction. The second DRP is there is no anti-epileptic prophylaxis given to patient as PTS prevention. Supposedly, patient should receive loading dose of IV phenytoin 15 to 20 mg per kg that being infused over 30 to 60 minutes and then followed by maintaining dose of IV phenytoin 100 mg given 3 times daily. The third DRP is patient still receive her antihypertensive medication despite of her hypotensive condition. The fourth DRP is there is no PCM being given to reduce patient's body temperature. And the fifth one is there is no insulin being given to control patient's blood glucose level. For PCI, there is no monitoring of glucose level even though patient has diabetes mellitus. Second, there is lack of monitoring for phenytoin level as patient has renal problem. And lastly, lack of GCS monitoring.
Moving on to the recommendation of treatment for patient which is treated as septic shock, we plan on starting patient on IV fluid resuscitation, consists of IV ringer's lactate, which is a type of crystalloid fluid, 30 ml per kilo within the first 3 hours. Because the patient is going to be on vasopressin therapy according to the Surviving Sepsis Campaign International Guidelines for Management of Sepsis and Septic Shock 2016, we should target the new mean arterial pressure to be 65 mm. Next, since patient BP is very low, we decided to give IV norepinephrine 10 microgram per minute, which is equivalent to 0.6 mg per hour, and the new targeted BP is as mentioned before. The last part is the antimicrobial therapy, where we suggested to give in accordance with National Antibiotic Guideline is IV cefuroxime 1.5 gram every 8 hours plus IV metronidazole 500 gram every 8 hours for 7 days. Reason is that this combination of antibiotic has a broad spectrum of activity, and at the moment we still does not have the culture and sensitivity lab test result.
To assess the effectiveness of the treatment, signs of infection and sepsis should be monitored. Besides lab results, general conditions of the patient must be assessed. This can be done by obtaining Glasgow Coma Scale scoring and also hemodynamic status of the patient. Effectiveness of phenytoin can be assessed by observing FITS chart. For safe use of antibiotics, it is important to observe for any hypersensitivity reaction and the occurrence of thrombophlebitis at IV insertion sites. Surgical sites should be monitored to detect any early signs of infection. For phenytoin, albumin levels and readings of liver function tests should be obtained in order to make dose adjustments. Phenytoin toxicity can be monitored by observing for nystagmus, ataxia, tremors, and so on. Glucose levels should be monitored to prevent any hyper or hypoglycemic episode.
In order to enhance patient care, these are some of the pharmacist's intervention. First is antimicrobial stewardship, which is important to choose suitable antibiotic regimen according to appropriate indication. Next is stress ulcer may happen in patient with mechanical ventilation more than 48 hours, so it is important to determine the necessity of the prophylaxis. Next is dose adjustment in order to ensure the efficacy and safety of medication. So renal function should be monitored since some of the medication depends on the renal function. Lastly is deep vein thrombosis monitoring as the patient limited mobility, so review all the needed information before started prophylaxis.
That's all from us. Thank you for listening.